Invite Dr. Shalin Agarwal to give his lecture on TACE and TARE, staying on course on transplant. Dr. Agarwal.
So thank you, chairpersons, and thank you, Dr. Ramdeep, for having me here. And I see so many of my old colleagues and friends sitting here, so it's a nice, small, warm gathering here. Okay, so my brief today is to talk about the role of these regional therapies, that is TACE and TARE, with respect to transplant. So as we all know that basically TACE and TARE can be grouped as regional therapies, and they have three roles in the setting of management of HCC in cirrhosis. So it's been recommended as a first-line treatment for intermediate stage HCC, that is the BCLC guidelines, as per the BCLC guidelines. Then with respect to transplant, these regional therapies have two roles, either as bridging to liver transplant for HCC, usually within the Milan or the slightly expanded UCSF criteria for patients awaiting liver transplant. That is, it's been said that the waiting time should be at least 6 months. Or as a downstaging modality to accepted liver transplant criteria, again usually the Milan criteria. So just a slide about the bridging therapies. Both these modalities have been widely used, especially in the West, as bridging therapies and with very good outcomes. Usually the drop rates at 6 months are around 20 to 25% without any pre-LT treatment for patients within Milan criteria. But by bridging these patients with either TACE, TARE, or RFA, usually it's been the TACE which has been used more often, you can reduce the dropout rates from 25% to nearly 5% at 6 months. So very useful in this setting. However, in the Indian setting, especially North India, where LDLT is the primarily mode of liver transplant, it may not be very relevant because we are not bridging our patients, we are actually downstaging our patients. It is a standard recommendation as per the ASLD guidelines, but mind you, the level of evidence is still very low. And more than 90%, despite that, more than 90% patients awaiting liver transplant in North America and Europe undergo some form of bridging these days. TACE is the most frequently used modality. However, if we go by the data, the percentage of TARE has increased to nearly 20%. But what is the impact of bridging on disease recurrence and overall survival? This was a very nice retrospective multi-center US study published in Annals in 2017, and it clearly showed that out of the nearly 3,600 patients, those receiving loco-regional, that is bridging with loco-regional, versus those who underwent upfront transplant, there was no difference in 1, 3, and 5-year recurrence-free survival, or the recurrence rates. So the impact of these modalities, that is regional therapy, on tumor recurrence and survival, despite reducing the dropout rate, was nil. That is, upfront transplant versus bridging or downstaging, with Milan it is called bridging. So there was no difference in outcomes in terms of recurrence or recurrence-free survival. And so this was a meta-analysis published in 2016 from China, and it clearly said that for patients meeting the Milan criteria, preoperative loco-regional therapy did not affect survival rates following liver transplantation. So it's very clear, if you have a patient within Milan and you are going to do an LDLT, till date there is not enough data to support the use of these therapies. However, there is a caveat, and when from the same data subgroup analysis was done, they found that when you are talking about complete pathological response on explant pathology, which is to the tune of around 23% in this large study of around 3,500 patients, so these patients did have much lower, significantly lower recurrence rates to the tune of 5% versus 16% without complete response. And this study also showed that smaller tumor volumes, lower baseline AFP, good AFP response, lower mild and younger age were the predictors of complete pathological response. But this cannot be predicted beforehand. So you have some guidelines or some pointers towards complete pathological response, but this is a very small subgroup of patients. Now coming to the downstaging, it was way back about 15, 16 years ago that this was a result. This was a retrospectively performed study. So it was published from Italy, and they showed that if you expand your criteria beyond Milan, moderate expansion to somewhere a little beyond UCSF, then you can get survival similar to those within Milan criteria after downstaging. And subsequently, number of studies have been published. One of the most quoted studies is by the UCSF group, Professor Yao's group, where they compared the so-called UCSF downstaging criteria, which is just a very mild expansion of their standard UCSF criteria. And they showed, compared 180 patients which were outside Milan, but within their downstaging criteria, with those within Milan, and they found that successful downstaging could be performed in 65% patients, and the results were comparable to those within Milan. So with these couple of studies, these are the two most landmark studies which have been quoted widely, but there are other studies also. It became established that if you expand the criteria and downstage these patients within Milan, you have almost equally good results. But then the same group analyzed the data further, the UNOS data, and they found that can you just go on and on with any tumor downstage? If you're successfully able to downstage within Milan, you'll have equally good results. So the answer was a big no. And this is a study which quotes that published in Hepatology in 2019. So they compared 74 patients who were within UCSF downstaging criteria with those which were beyond, what they call the all-comers. So one, the success of downstaging was significantly lower, 64% compared to 84%. And then finally, only 13% of the all-comer group could undergo a transplant because the tumor progressed while waiting in the all-comer group compared to the UCSF downstaging criteria, which actually, I will say again, are more or less similar to the standard UCSF criteria. And obviously, the survival outcomes were also much poor. So it is not that downstaging is a panacea for all kinds of HCCs, and the data what is available, it has no use for Milan patients within Milan, and good results for patients who are within the UCSF criteria, but if you go beyond that criteria again, your results fall drastically. So, and this was UNOS data which was analyzed from multi-center data. So again, they use the same criteria, that is the UCSF downstaging criteria. The previous study was a single center. This is the multi-center data which was analyzed. And again, similar results, that if you go beyond the UCSF downstaging criteria, your recurrence rates are much higher, significantly higher, and correspondingly lower survival. So if the benefit downstaging has to be availed, you have to set limits. And what they said, the authors have said that you need to do it prospectively. You should lay down your criteria, which they have laid down as UCSF, and then you can get some positive results. Otherwise, the results are very wishy-washy. And this was, again, a multi-center study. This was a non-North American study. This study actually included large number of centers, 47 centers from Europe and Latin America. And it was a data from retrospective data for spanning over almost 20 years. So there were 2,500 patients in this study, of which 70% received locoregional therapy, majority of them TACE, but even here 83% of the patients were within Milan. So, and 10% within the UCSF downstaging, and only 6% beyond. But what the data shows, that the recurrence rates in this study were much higher in the all-comer group, 54% compared to 13% for patients within Milan. So, expanding outside Milan is not helpful, and this was the only randomized trial published by the Mazzaferro group. But this is just showing that if you successfully downstage and transplant versus no transplant, so transplant gives you much superior results. And couple of slides about comparison of chemoembolization versus radioembolization. So these are two centers from the same centers, the Chicago group, and they have shown that when you talk about partial response or downstaging to within Milan or recurrence-free survival, TARE is superior to TACE. But when you look at the multi-center data from North America, their outcome is similar in terms of downstaging. And one slide is missed. This is our data that I'm published. I think one slide got lost somewhere. So this is a data on nearly 600 patients that we have transplanted for HCC over the last 15 years. Just 1 minute. And 80% of these patients underwent TACE. And when you talk about the different criteria, so 20% patients within Milan received downstaging, successful downstaging, that is complete or partial response, was 74%. 40% of the UCSF received downstaging, 61% success rate. And when you went beyond UCSF, again, very poor results. That is only 1/3 patients could be successfully downstage. And when we looked at our data, and about 157 patients underwent locoregional therapy, that majority of them TACE, as I showed in the previous slide. There was no difference in the overall and recurrence-free survival when we talk about the patients within Milan. When we move upwards to the UCSF, 56 patients, again, no difference between downstaging and upfront transplant group, although the graphs, the lines start separating after 5 years. So maybe long-term outcomes may be better, but we have to wait for further results. And when we went beyond UCSF without portal vein tumor thrombosis patients, so again, there was no difference between upfront transplant and downstaging. And with each increase in criteria, the overall survival is coming down. And when we compared the overall survival and recurrence-free survival for patients within Milan and UCSF who were downstage to Milan, so the results are very similar to the international results, that these patients had survival similar to the Milan group. But I have a point to make here that patients within the UCSF group, even without loco-regional therapy, have results similar to Milan, and that's why UCSF criteria have been accepted widely. But when you downstage patients beyond UCSF, even after successful downstaging, the results are much inferior. The survival of these patients who are beyond UCSF, even if you downstage them to within Milan, their survival remains significantly inferior to the patients within the Milan group. So I'll summarize by saying that loco-regional therapies by preventing waitlist dropouts are useful, very useful as bridging therapies, although the level of evidence is low. Downstaging does not improve survival outcomes for tumors within Milan. For tumors within the UCSF downstaging criteria, it gives results similar to those within Milan, and that's why it has been supported. The use of downstaging has been supported for this group. For tumors outside UCSF, overall survival and recurrence outcomes are significantly inferior despite successful downstaging. So I would like to summarize by saying that the utility of downstaging appears to be more as a tool for selecting tumors with good biology, and the real impact on improving survival and recurrence outcome remains debatable. Thank you for your kind attention.
Thank you, Dr. Shalin. Only we can allow 1 or 2 questions.
Hi, Dr. Shalin, thank you. My question is regarding the use of the term downstaging. If you're taking tumors within Milan and you're doing a loco-regional therapy, then technically it's not downstaging, it's bridging, right? I mean, you said that 24% of your patients within Milan, you're giving TACE and you're calling it downstaging. That's not downstaging.
Well, yes, these terms have been used interchangeably, but you're right. Bridging, the term is ideally used when you are waiting for transplant and you have a wait times and there's a risk of dropout. So if you go by the definition of bridging, but in our setting, we are not actually waiting for transplant. And many of these, see, only 20% of the Milan patients received therapy, and these patients have been included in our data because they came already to us after receiving the therapy. So for analysis we have used, you can you can use downstaging or bridging, it doesn't make a difference. I'm just talking about whether loco-regional therapy helps for patients within Milan or not, and the answer is big no. Our data of 157 patients as well as the international data doesn't support the use of...
Because technically downstaging would mean when you're doing
yes,
for tumors which is beyond your
tumors.
criteria.
But well, even within Milan, patients with after receiving therapies have shown complete necrosis. So by that, the tumor has come down. But my idea of putting this, talking about was with respect to the outcomes. The rest is semantics.
Hi, Dr. Shalin, very good talk. Just one comment and one question. The criteria, they are ever expanding. Even Kyoto, they came out with 10 number tumors and 5 centimeters. But whatever meta-analysis they show the size to be more important than the numbers. So bigger impact on disease-free survival and recurrence rates based on the size of the tumor rather than the number. So you're limiting your size to 5 centimeters or less, recurrences are less. Now, I would want to know, like most of the studies show that Milan does not require it. So if a PET positive Milan you have, would you like to do a downstaging? Second,
high
AFP value and PET positive. And second is, now that the immunotherapy is available, would you consider doing immunotherapy followed by TACE or TACE followed by immunotherapy? Because somebody asked me this question and never really thought about it. We are blocking off the blood supply. And no, for any pre-operative downstaging protocol. When we are doing TACE, we are actually blocking off the blood supply to the tumor, and then we are giving immunotherapy. Will that be more
So there's hardly any data. This is just, we can conjecture that, as you rightly said, that with TACE you are blocking the blood supply, but actually these tumors, as they grow, they get their new blood supply, and that is how progression even after TACE occurs.
Because there are studies which show 80% necrosis with the immunotherapy, and then they have done TACE, which probably logically makes sense.
Actually, TACE still, as per the data goes, has only been combined with lenvatinib. That is these multikinase inhibitors. There is no data where a combination of immuno plus TACE, maybe some case reports, but there is no data to support that. So I'm not in a position to answer on that. But yes, TACE plus lenvatinib has been tried, and they start before TACE, in some studies even 2 days before TACE, and then they do the TACE as a kind of sandwich therapy.